Hi everyone, my name is Mohadese Ahmadzade and I'm a postdoc research fellow in the Department of Radiology at Baylor College of Medicine. Today I'll be presenting Advancing MSK Imaging. In this blog titled Next Generation MSK Imaging, we'll be covering 4 key imaging technologies: UT and ZT MRI, MRI-based synthetic CT, photon counting CT, and augmented reality in the IR suite. This blog was edited by Dr. Stewart and Dr. El-Sayes. To set the stage, MSK disorders affect hundreds of millions of people worldwide. They're a leading cause of disability, and imaging is absolutely central to diagnosing them, planning surgery, and tracking disease over time. The problem is that our 2 main modalities each have a fundamental limitation. CT is excellent for cortical bone, it's our gold standard, but it delivers ionizing radiation, and that matters a lot when you're imaging children or patients who need repeated scans. A standard MRI, on the other hand, is great for soft tissue, cartilage, and marrow, but it produces almost no signal from cortical bone. The T2 relaxation times in dense bone are just too short for conventional sequences to capture. So patients with complex pathology often end up needing both, and that's the gap these new technologies are trying to close. To be more specific about that gap, when a patient has complex spinal pathology or suspected bone disease, it's not uncommon to order both an MRI and a CT. That doubles the radiation exposure, the cost, and the workflow burden, and it doubles the number of appointments the patient has to make. For pediatric patients specifically, and for anyone on a repeated imaging schedule, that radiation accumulation is a real concern. And then there is a second problem that doesn't get talked about enough: occupational injury in the IR suite. Interventional radiologists frequently turn their head away from the procedural field to look at imaging monitors. Over a career, those repetitive head turns contribute significantly to cervical strain and MSK injury. That's the problem augmented reality is designed to address. The first paper is a scoping review by Ferrari and colleagues published in Radiography in 2026. They identified 18 studies examining ultra-short echo time and zero echo time MRI sequences for MSK applications. So how do these sequences work? A standard MRI can't image a cortical bone because the signal decays too fast. But UT and ZT use radial case-based acquisition with echo times as short as 0 to 0.34 milliseconds, far shorter than conventional MRI. That lets them capture bone signal before it disappears, and the resulting contrast is comparable to CT on T2 star weighting. Acquisition times range from about 3 to 12 minutes. Utility was demonstrated across the spine, lower limb, and head and neck. One notable advantage is a substantial reduction in metal susceptibility artifact, which is valuable in patients with orthopedic hardware. Also, ZT specifically has a near silent acquisition profile because of minimal gradient switching. That is a real benefit for anxious patients, children, and patients with cognitive impairment. The limitation the authors flag are longer scan times compared to CT, partial volume effect on small structures, and the fact that not all MRI platforms support these sequences yet. But AI-assisted reconstruction is cited as a promising pathway forward. The second paper is a comprehensive review by Stewart and colleagues in the Journal of Bone and Joint Surgery, also 2026. They covered the full landscape of MRI-based synthetic CT techniques, including ZTE, UTE, 3D gradient recalled echo, and deep learning synthetic CT, which they call DLSCT. The deep learning approaches are particularly interesting. Programs like Bone MRI, MRCAD, and AirRecon DL are trained on paired MRI CT datasets, so they learn to predict Huntsville units directly from MRI input, essentially generating a CT equivalent image from an MRI scan. And the landmark development here is in May 2025, Bone MRI received a Medicare billing code. That's a significant step toward routine clinical adoption. Early studies across the shoulder, hip, knee, and spine, including in pediatric population, show high agreement with conventional CT. So the clinical implication is that a single well-designed MRI protocol could eventually replace the dual CT plus MRI acquisition for many patients, reducing visits, reducing the need for sedation in kids, and lowering overall imaging costs. The third paper is a review by El-Sadani and colleagues in the BJR published in 2025 on photon counting detector CT in MSK imaging. This is a fundamentally different detector technology. Conventional CT uses energy integrating detectors, which means photons hit the detector and the total energy is summed. But photon counting detectors instead count individual photons and record their energy separately. That gives you improved spatial resolution, lower electronic noise, and inherent spectral imaging capability. And critically, you get all of that without a meaningful increase in radiation dose. Clinical application reviewed include a detection of trabecular microarchitecture, subchondral cysts, and early fracture callus, and quantitative bone quality metrics. The spectral capability enables virtual monoenergetic imaging for metal artifact reduction in post-operative patients and material decomposition that can be used to diagnose gout or characterize bone marrow in myeloma. The headline finding is that in patients undergoing pelvic imaging for femoroacetabular impingement planning, PCD-CT achieved equivalent or superior imaging quality at a 50% dose reduction compared to a standard CT. As this technology becomes more widespread, radiologists and technologists will need training in spectral reconstruction and material decomposition interpretation. The fourth paper is from Jalil and colleagues published in JVIR in 2026, reporting on a head-mounted augmented reality display system. They looked at 14 needle replacement procedures, specifically kyphoplasties and spinal biopsies, and performed kinematic analysis comparing AR-guided versus a standard monitor display. The results were striking. Using AR, there was a statistically significant 47.6% reduction in head turns, and the magnitude of each turn was also reduced from about 78 degrees down to about 60 degrees. They also surveyed 9 interventional radiologists who used the system. Comfort score were 5 out of 5, ergonomic impact 5 out of 5, willingness to reuse 5 out of 5, but image quality was rated 3 out of 5. That's the primary area identified for improvement. The authors note that AR appears more beneficial for procedures that require sustained frequent image reference, exactly the profile of MSK interventional procedures like kyphoplasty, spinal biopsy, and abscess drainage. For specialty where occupational cervical injury is a documented and prevalent problem, this is a meaningful development. So, pulling these 4 papers together, what do they mean for practice? For radiation-free bone imaging, the trajectory is clear. UTE, ZTE, and deep learning SCT are moving from proof of concept into clinical deployment. A single MRI may suffice where bone CT and MRI were previously required. For photon counting CT, this doesn't replace CT, it raises the ceiling of what CT can do. Higher resolution, lower dose spectral capability, and better performance in postoperative patients. It expands CT's utility without compromising its core strengths, but it does require new interpretive skills. And for augmented reality, this is a direct response to an occupational health crisis. If we can reduce head turns by nearly half during MSK procedures, and operators find the system comfortable and useful, that's a meaningful intervention for long-term radiology's well-being. Across all four technologies, AI is the shared enabling pathway, improving signal quality, reducing acquisition time, and broadening clinical applicability. To close, MSK imaging is undergoing a genuine multi-front transformation. These aren't speculative technologies. They're at various stages of clinical deployment with real evidence behind them. The common thread is that more diagnostic information, lower radiation dose, and better workflow are all achievable simultaneously. None of these tools is universally available yet, and none is fully validated across the breadth of MSK conditions, but the direction is clear. Radiologists and trainees who develop familiarity with these tools now will be best positioned to lead their adoption and to design the large multi-center trials still needed to establish definitive evidence. That wraps up our ACOR education summary on next-generation MSK imaging. You can find the full blog and all four references linked below. Follow us at ACOR on Facebook, Twitter, and LinkedIn for more radiology education content.